And so the next question is, which is true? Select all that apply. CLL is often indolent and treatment is for palliative intent. Overall survival is measured in years. Limited stage follicular lymphoma is curative with radiation therapy. Multiple myeloma is incurable, but treatment can offer long-term survival. Are people still able to be on the interactive app? Okay, so the answer is all three, and so all three are true. All right, so we're moving forward to our next talk, and so managing hematologic emergencies in malignant hematology. And so the speaker for this will be Dr. Lalit Saini. And so Dr. Saini is an associate professor of hematology with a keen interest in clinical trials and advancing therapeutic approaches for acute leukemia. His research is centered on improving patient outcomes through clinical trials and quality improvement initiatives. Dr. Saini also focuses on developing innovative treatment protocols and optimizing leukemia care. At the end of this presentation, your learning objectives: identify common hematologic emergencies, discuss the initial workup and management of these emergencies, recognize potential pitfalls and complications during emergency management. So, clinical case check-in. And so how should we work up this patient further? And so we're back to Richard. Now he's got diffuse large B-cell lymphoma as per the ultrasound-guided biopsy. And so he undergoes additional lab testing and CT staging scans. And so the blood work usually includes CBC, renal function, liver function. We want to check the uric acid as we worry about things like tumor lysis. We also sometimes would want to evaluate for PTT and INR to assess for derangement indicating consumptive coagulopathy, especially in the aggressive disease like aggressive lymphomas or leukemias. Hepatitis B screening is also important, as often we may expose patients to immunosuppressive therapy, and sometimes that can lead to reactivation of hepatitis B. CT scans for staging for this patient reveals extensive involvement with bulky masses. And so bulky is a term that's often used in these radiological reports. In terms of true definition within the lymphoma community, we consider anything, 7.5 to 10 centimeter as bulky. Masses in close proximity to L2 spine. And so certainly that, provides additional insights in potential complications that may occur in this patient. And so the lab results are concerning for the following. So there's a prolonged PTT and elevated INR. There's a mild renal dysfunction, and also elevated uric acid and LDH. And so questions to ponder on: what hematologic emergencies should be anticipated in this patient based on the findings above? And how should these emergencies be managed? All right, so Dr. Saini.
Is there a pointer, Choi? No, it's a pointer. Power button? Perfect. All right, thank you very much, Chai. So over the next maybe, interview. So over the next 20, 25 minutes or so, we'll talk a little bit about some of the hematologic emergencies that we see in malignant hematology. So these are some disclosures. I've been on a couple of different advisory boards for a few different companies. So over the next few minutes, like Dr. Pua said, we're going to talk about the common hematologic emergencies, some of the workup and management of these emergencies, and some of the pitfalls when you're starting to treat patients who present with these emergencies. So as we all know, the prevalence of cancer is growing globally every year. cancer patients, they can present in lots of different ways. And anyone who deals with cancer patients knows this. They can have sometimes very, very non-specific symptoms, and sometimes they might present with symptoms that are concerning and that require urgent and emergent treatment. Patients can present anywhere, really. They can go to the emergency room, and that's where I often get my patients from after they present with symptoms or features suggestive of leukemia. They can present to the primary clinics. They can present to our own clinics as well. So lots of different ways. And it's a little bit important to understand how these patients present and how to respond to these presentations. So amongst patients who don't present in urgent emergent ways, it's still important to screen these patients for the urgencies and emergencies that might be happening that we may just not know about. So these are some of the emergencies that I was going to touch on. So the first one is leukostasis, which means lots of white blood cells. Talk a little bit about acute leukemia and some of the complications that we see in these patients, tumor lysis syndrome and DIC. We'll touch a little bit upon hyperviscosity syndromes and hypercalcemia. And I was going to talk about spinal cord compression, but I think we're going to leave that alone. So this is a story of a patient that I recently saw. So he's a 76-year-old gentleman who presented to his family doctor being unwell for about 2 or 3 days or so. When I talked to him a little bit, he said, well, it's probably been going on a little bit more than that, maybe for a few weeks. He's got a little bit of dyspnea at rest, worsens with exertion. He's been having some bruising for the past few weeks as well, and no recent infections. He goes to his family doctor, and the family doctor does some blood work and tells him to go to the emergency department right away. So here's a question for the audience. So you've got these 3 different CBCs here. So the first one has a white cell count of about 150. The next one has a white cell count of 110. And the next one has a white cell count of 105. So looking at these CBCs, which one has you the most worried? So if you think the answer is A, raise your hand. No one is worried about a white cell count of 151? Brilliant, I love it. What about a white cell count of 110? Anyone worried about that? And a white cell count of 105, anyone worried about that? So hopefully this helps a little bit. So when you look at the white blood cell count, the white blood cell count by itself is sometimes not very useful. So what we really want to take a look at is the differential, which is really what's going to help us. So here the white cell count's 150, but the lymphocyte is a predominant cell. So this one we're not too worried about. We can wait until the next morning to give the hematologist a call. This person's got a white blood cell count of 110, but they've got lots of these blast cells here. So this one we're a little bit worried about. So this is the patient for whom we call the hematologist at 3 o'clock in the morning and say, listen, we need help. And you've got this patient here with a white cell count of 105, but again, the differential is what really helps you out. So here you can see the blast count is 2, lots of neutrophils, lots of these myeloid cells. So this patient probably has CML and not too worrisome. But really it's this person here that we're really worried about. But the key thing that really helps you is the differential. Oh, okay, we did that one. And no one raised their hand except for like 3 people. So, so questions that come to mind when you look at those CBCs. Does this patient have acute leukemia? Does this patient have any complications of the acute leukemia? And looking at the white blood cell, a number of concerns come to mind as well. Does this patient have hyperleukocytosis? Does this person have tumor lysis syndrome? Does the patient have DIC? And it's not, so the first question, does the patient have leukemia? There's really not a lot of good relationship between the white blood cell count and does the patient have leukemia. So patients with very high white cell counts, like we saw, can sometimes not have leukemia. They may have a chronic leukemia. And patients with very low white cell counts, 1 with neutrophil counts of 0.3, a couple of blasts here and there, could have rip-roaring leukemia. In fact, I've seen patients who have nothing more than a mild neutropenia, and they've got rip-roaring leukemia in their bone marrow. So for any time you see these kinds of presentations, you're always worried about some of the complications that patients may have, regardless of what the white blood cell count is. So the first one we talk about is hyperleukocytosis. So this is often defined as a white blood cell count of more than 100. And like I said, symptoms can occur even if the white blood cell count is lower than 100. Symptoms can include a wide variety of nonspecific manifestations. They can have central nervous system symptoms, respiratory symptoms, ophthalmic symptoms. And this is a nice table that sort of goes through some of these symptoms. Patients may have just something simple as headaches, dizziness, vertigo. Sometimes patients can present with seizures. They can get blurry vision. Dyspnea is extremely common. Sometimes they'll have things like fever and priapism, et cetera, as well. So hyperleukocytosis, what it does is it can cause microvascular obstruction. And there's abnormal expression of adhesion molecules on the surface of blast cells, specifically blast cells. And this is most commonly associated with large and immature cells. So these are things like blasts. So mature cells like neutrophils or mature cells like lymphocytes generally don't cause hyperleukocytosis. So if a patient has a white cell count of 105, but it's all lymphocytes, unlikely that patient's going to have hyperleukocytosis-related symptoms. If the white cell count is 115 and it's mostly neutrophils, unlikely that patient's going to have issues with hyperleukocytosis. So this is a CT scan from a patient who does have hyperleukocytosis, and you can see all of these infiltrates in there. So treatment of hyperleukocytosis should be started immediately, and it's very, very important to control the white blood cell count. And there's two parts to that. So the first one is you want to prevent the rapid growth of the cells. And the second one is you want to try to kill the cells that are already there. So you can use hydroxyurea to do that, which is an advice that I often give physicians when they call me. You can use chemotherapy, more extensive chemotherapy, depending on the clinical condition of the patient. And you have to keep in mind that as you kill these white cells, you might cause another problem that you need to deal with. And that's tumor lysis syndrome. So it's extremely important to start patients on treatment or prophylaxis for tumor lysis syndrome at the same time as you're trying treatment for the hyperleukocytosis. It's very important to avoid unnecessary transfusions because all they're going to do is increase the viscosity. Patients come in with a hemoglobin of 65 and the instinct is to transfuse them. Maybe just hold off on the transfusion for a little bit and let's get the white cell count down a little bit, and then we can start transfusing them. People often want to give lots and lots of hydration as well, because the idea is that the hydration is going to dilute out the white blood cells. But more often than not, what you end up doing is you're giving so much hydration that it just goes into the lungs and makes that dyspnea worse that the patient is already coming in with. It's a great way to put patients into the ICU because then you don't have to worry about the respiration. Leukapheresis can be used, which means that you call the nephrology service, they put in a line, they take those white cells and they get rid of the white cells. You have to be very selective with the patients that you use this for. So we're going to back to our CBC. So the patient that we're most worried about is this patient here with the high blast count. This patient could have probably won't have hyperleukocytosis because it's mostly more mature cells that we're dealing with. And this patient probably won't have hyperleukocytosis either because it's mature cells that we're dealing with. So this is a person that we're worried about and waking up the hematologist at 2 in the morning. So what else are these patients at risk of? They're at risk of tumor lysis syndrome and DIC. And the two things kind of go hand in hand with patients who present with blasts in their blood. It doesn't have to be a high number of blasts, just any blast, you start to worry about these two things. So if you get a CBC report back that shows blasts, your next call to the patient should be, let's screen you for TLS and DIC. It doesn't matter if they've got 1 blast or 2 or 100. This is what we're screening for. So tumor lysis syndrome is a constellation of metabolic abnormalities that occur when the cancer cells, the blast cells, are dying, generally in rapidly growing malignancies, and that can include high-grade lymphomas that Dr. Pua and Dr. Mount talked about, but also leukemias as well, and rarely solid tumors. It can be present spontaneously, so meaning patients present with it, or it can happen because of the treatment. DIC is similar. It's abnormal activation of the coagulation system. And lots of different mechanisms have been postulated for this, and it can lead to arterial or venous thrombosis. Leads to abnormal bleeding as well. So you can get intracranial hemorrhages, which is a dreaded complication that we worry about. So any patient with new blasts in the blood who has a headache, they've got an intracranial hemorrhage right off the bat. You should get a CT scan for those patients. Any cancers can cause this: leukemia, solid tumors, lots and lots of other causes, and it can occur spontaneously. So for tumor lysis syndrome, in terms of presentations, patients may present with some clinical symptoms like tachypnea, volume overload, arrhythmias. With DIC, they may present with bleeding symptoms or clotting symptoms. So be very mindful of that in patients who are presenting with new blasts in the blood. The lab markers for tumor lysis syndrome are things like elevated uric acid levels. This is because of nucleic acid metabolism. The elevated uric acid can build up in the kidneys and cause acute kidney injury. The acute kidney, you need the kidneys to get rid of all that volume that you're giving patients, but they can't because now they're injured. You need them kidneys to get rid of the phosphate and the potassium, and they can't, so that can make hyperkalemia and hyperphosphatemia worse. So protecting the kidneys is extremely important part of managing tumor lysis syndrome. The DIC can present with elevations in the PT, elevations in the PTT, and reduced fibrinogen levels. You might see some cystiocytes, thrombocytopenia, and anemia. So treatment really comes down to trying to prevent tumor lysis syndrome as much as possible with using allopurinol, which is xanthine oxidase inhibitors. You can use this newer agent, which hasn't really been shown to be any better than allopurinol. But if patients already have a high level of uric acid, then you can use respiracase. You need to manage the individual metabolic abnormalities as well, so the renal failure, the potassium, etc. And you need to do frequent monitoring. With DIC, really the trick is to treat the underlying cause, and for some patients, you'll give platelets and fibrinogen. There's always been a thought, well, maybe you're adding fuel to the fire, but really the patient comes first. And so if they're having significant abnormalities with bleeding, then you need to replace platelets and fibrinogen. So back to our patients here. I'm not sure why I put this in. We'll move on. The story continues. So my patient had a chest x-ray, which showed that he's got some infiltrates. He may have had a pneumonia, or unclear whether he's got a pneumonia on the chest x-ray or whether this is symptoms of hyperleukocytosis. We screen him for TLS. His renal function is okay. Uric acid is a little bit high. We start him on allopurinol and hydroxyurea to bring the white cell count down and give him gentle hydration, taking into account his age. We screen him for DIC. His PT and PTT are up a little bit. His fibrinogen is low. We're concerned that he has DIC. But what does this mean in the context of the blast cells that he's got? So there's a very particular type of leukemia called APL leukemia, or acute promyelocytic leukemia. And this particular leukemia is extremely prone to DIC. About 15 to 30% of patients who have this type of leukemia will die within the first 24 to 48 hours of presentation. This is not data from developing nations. This is data from Sweden and from Canada. This is the early mortality that we have in Canada with these patients. And this happens because of a translocation between chromosome 15 and 17, leading to a new protein called the PML-RR alpha protein. And the main manifestation of this is DIC. So if you have any patient who presents with a new blast in the blood, the next test, if you're going to do a single test, is just check the patient for DIC. And if they have DIC, this is a phone call to the hematologist, regardless of what time it is, day or night. And we assume the patient has APL, regardless of whether the patient has APL or not. So new blasts in the blood is equal to APL for all intents and purposes. And we start the treatment for this regardless of what time it is, because the mortality is so high within the first 24 to 48 hours. And if the patient survives that first 24 to 48 hours, then they can have a very nice long survival, close to 98, 99%. But those are the patients who get the treatment. So back to our patient, the testing shows that he doesn't have APL. And over the next few days, we bring his white cell count, we start him for treatment for AML, and he's doing okay. So we've got a few more minutes, and I'll talk about case 2. So this is a 56-year-old woman that I saw with a 2-month history of easy bruising. She presented to the emergency department and was found to have a platelet count of 16. She was referred to me for ITP. So we treated her like ITP initially, but when we saw her, she mentioned that she's been having some blurry vision for the past few weeks. We did some additional blood work, which showed she's got anemia, normal white cell counts, low platelets because of that was noted previously. My standard workup for these patients also includes a serum protein electrophoresis. Her total protein came back as very high, over 100, which raised the possibility of could this be a multiple myeloma? I'm not a myeloma physician, but when I saw the total protein was that high, I started to get a little bit worried. And I started to think, well, could this be myeloma? And if it was myeloma, there's a few things that I need to do to make sure the patient doesn't have complications of myeloma. And those are things like testing the patient for hypercalcemia, making sure they don't have renal failure, anemia, the bone lesions. And because this patient was having blurry visions and the total protein was so high, my thought was, could this somehow be related to the blurry vision that she's having? So hypercalcemia can be seen in lots of different patients and it can be seen in lots of different cancer subtypes, including solid tumors and hematological malignancies. So if you suspect multiple myeloma in a patient, or any cancer really, then that is a good idea to screen for hypercalcemia, which can cause all sorts of other problems. There's a couple of different mechanisms for the hypercalcemia. So it can be related to production of things like PTHRP, which is parathyroid-related peptide, or intact PTH. It can come from bone destruction or from production of vitamin D analogs by the cancer cells themselves. It can be associated with overt signs of malignancy, so lots of big lymph nodes, CT findings of problems in the lungs, etc. But some non-specific symptoms as well, lethargy, confusion. They may have polyuria, polydipsia. And of course, a diagnosis of the hypercalcemia is based on measuring the calcium levels, correcting for albumin or ionized serum calcium levels. So the treatment for hypercalcemia, which is what we've done for many years, is extensive hydration, being mindful of volume overload, bisphosphonate. You can use things like calcitonin. But if we're getting to these points, usually the patients are admitted to the hospital. So next, we thought a little bit about the a few other things. The remaining blood work came back for the patient, and she came back with an IgM of 50. And given the symptoms that she was having, the question was, does she have hyperviscosity? So this is when I called my myeloma colleagues and lymphoma colleagues to say, can you help me? I'm not a myeloma physician. So hyperviscosity is defined as an intrinsic resistance of fluid to flow, and it's most commonly seen in patients with paraproteins. So that the larger the paraprotein, so IgM is largest, that's more often associated with this, IgA less so, IgG less so. And higher levels increase the risk of symptoms, but it's not necessarily that a patient who has an IgM protein of 50, every patient with an IgM protein of 50 is going to have symptoms. That's not necessarily the case. Some might have it at 20, some might have it at 10, some might have it at 60. The presentations can be quite variable, ranging from headaches, dizziness, blurry vision, dyspnea, congestive heart failure, etc. Some things you might see on the blood film are things like rouleau. And if you see that, then you need to think about perhaps measuring the serum viscosity. You can measure the serum of immunoglobulins, which is what we did. And high GM means an urgent referral to hematology, which is what I did. I referred urgently to hematology. So treatment, when I referred the patient to hematology, he was transferred to she was admitted to the hospital. She got hydration. She also got plasmapheresis, which again means contacting our nephrology colleagues. And again, you want to avoid unnecessarily blood transfusions. So back to our patient, like I said, she was referred to one of my myeloma colleagues. Workup revealed she had a lymphoplasmacytic lymphoma, which Dr. Pua talked about earlier, and she subsequently underwent treatment for this. So in conclusions, patients with hematological malignancies can present in a myriad of different ways, some of them requiring emergent identification and management. Patient with new blasts in the blood that they've never had blasts in the blood have by definition APL until you prove it's not APL, because the mortality is so high for APL, you want to treat them as APL. And some of the things that can help you with that is checking the patient for DIC. If they have DIC, definitely treat them like APL. In any patient with new blasts, you want to screen them for TLS. You also want to screen them for hyperleukocytosis and make sure they don't have symptoms related to that. In patients with M protein, screen for hypercalcemia, symptoms of hyperviscosity. That's it. Questions?
Thank you, Dr. Saini. Any questions for the room?
It was great to see no one's concerned about a white cell count of 100. Love that.
My question is about water and hydration. So it was brought up a few times. And when it comes to excessive hydration versus perhaps hydrating to minimize TLS, what's the balance there? What is considered excessive?
So excessive is anything that puts a patient into further worsening of the respiratory status. So you can use gentle hydration to try to preserve their renal function. Many years ago, the thought was you can use urinary alkalinization as well, which we no longer do. But just gentle hydration, keeping in mind the volume status of the patient and the age of the patient. And if they're already coming in very, very dyspneic, you need to be even more careful with that.
Just wondering, any specific concerns when using respiricase? Any specific kind of tests that you might want to consider or questions you might ask?
So Dr. Pua is alluding to the fact that you don't want to use respiricase, which is actually breaks down the uric acid in patients with G6PD deficiency. So knowing the ethnicity of a patient can sometimes be helpful, or more often than not, we don't have time to test for G6PD deficiency, especially if things are happening in the middle of the night. But certainly if there's any history of it, you need to be very, very careful with using the drugs.
Any other questions? We've got a question from the audience virtually. Do you want an urgent call about any level of blast at 3 a.m. or just blast plus signs of DIC or TLS? And this is specific to Dr. Saini.
So if a patient has new blasts in the blood and they've never had blast before, the next test ordered is a DIC workup. And if the DIC workup is positive, meaning there's a low fibrinogen level, elevated PT or PTT, then yes, I want the call at 3 o'clock in the morning because that patient needs to be started treatment that night now. If a patient has had previous blasts in the blood and they've had them for years, then we don't need to be called at 3 o'clock in the morning. Any blasts in the blood, that's a good question. So let's go back to those CVCs that we showed in earlier. So the differential can help you figure out whether you need to call someone at 3 o'clock in the morning. A high number of blasts, high white cell count, please call us. If it's a low number of blasts, but the other parameters are not so concerning, that we can wait till the morning. But the simplest answer is, if you're worried in any way and you're not sure what those blasts are, call us. We're always happy to take a call.
Okay, thank you, Dr. Saini.